Lecture today is entitled CT and MR Evaluation of the Pregnant Patient, Maternal and Fetal Indications. So we're shifting gears a little bit from ultrasound, but why CT or MR in pregnancy? Well, I think we all agree that ultrasound is the study of choice for evaluation of the fetus and for abdominal and pelvic abnormalities in the mother. But unfortunately, despite our best efforts, sometimes with ultrasound, there are questions that are left unanswered. Ultrasound findings may not be definitive and additional information is required. CT or MR may be necessary for evaluation of maternal abnormalities, and MR can also serve as an important adjunct to ultrasound for assessment of certain fetal abnormalities. So the learning objectives for this lecture are to review the safety considerations involving CT and MR use during pregnancy, and then also to discuss specific applications in the pregnant patient, both obstetric and non-obstetric. So starting first with CT during pregnancy. The risk to the fetus is associated both with a radiation dose and also the use of iodinated contrast. And when we talk about risk from radiation to the fetus, we talk about radiation-induced teratogenesis and carcinogenesis. Now, a lot of the data, or the data that we have here, is basically extrapolated from data in atomic bomb survivors that were exposed in utero to high doses of radiation. And basically, this data has been extrapolated down to the potential effects of lower doses. So we really don't have any direct evidence that diagnostic imaging and the dose of radiation involved with this causes harm to the fetus, but there is certainly a potential risk if we extrapolate that data. So in terms of radiation-induced teratogenesis, the greatest risk to the fetus will be during weeks 8 to 15 after conception, and because this is that critical time of organogenesis. And it's been shown that the CNS is most radiation sensitive, and at high doses, the fetus can develop problems such as microcephaly, microphthalmia, mental retardation, and cataract formation. Now, depending upon which publication you read and which organization you refer to here, what is the threshold dose, that critical threshold dose, above which, if the fetus is exposed to this dose, you would expect to see an increased risk for these congenital malformations. And that ranges anywhere in the literature from 5 rads up to 20 rads. But most people take this 5 rad dose as the cumulative dose above which you do not want to expose the fetus during pregnancy. Now, the issue of radiation-induced carcinogenesis is a controversial topic, but most agree that there is a small but definitely finite risk of developing childhood cancer, an increased risk of childhood cancers after a fetus has been exposed in utero, and the most common one is going to be leukemia. The increased risk here is felt to likely require a dose of at least 1 rad, or 10 milligray. I'm going to stick to pretty much using rads throughout my talk as a measure of absorbed dose, radiation dose. So what does this boil down to? Well, the estimated risk of childhood cancer per 1 rad exposure is felt to be up to 3.5 times the normal incidence. And fortunately, the normal incidence of childhood cancers is very low. So this boils down to 1 cancer per 10,000 fetuses exposed in utero. So what are some of the summary statements that some various organizations have regarding the use of X-ray imaging during pregnancy? Well, the American College of Radiology states that no single procedure, diagnostic procedure, results in radiation doses that threaten the well-being of the developing fetus. The National Council for Radiation Protection states that fetal risk is negligible at less than or equal to 5 rads, and the risk of malformations is significantly increased only at doses greater than 15 rads. And the American College of Obstetrics and Gynecology states that exposure to less than 5 rads has not been associated with an increased risk of fetal anomalies or pregnancy loss. And I refer you to this article, which I found to be very helpful. It summarizes a lot of data regarding these issues. It's entitled Safety of Radiographic Imaging During Pregnancy. So in order to put this in the context of what the dose to the fetus is from the various diagnostic imaging tests that we perform, I give you this table, which is again from this same article. And again, the fetal dose here is given in rads. And what they've also done is they've given the number of each type of exam that the fetus would have to be exposed to in order to reach that critical 5 rad threshold dose. So obviously these numbers are going to vary somewhat depending upon the particular techniques and technical parameters used, but you can see that the dose to the fetus from a chest x-ray is very low. Obviously the fetus is not going to be directly in the x-ray beam here, and the dosage is going to be from scattered radiation. The dose will increase for an abdominal film where we see it's about 1/4 of a rad, and then you can see the other numbers here. Chest CT, the dose is less than a rad. An abdominal CT, the dose is about 2.5 rads. So you can see that one examination is going to put you close to that 5 rad threshold limit. And just for interest, the estimated exposure to the fetus just from background radiation is about 1/10 of a rad. Now, I also found this article to be very helpful, and it's entitled, "When a Pregnant Woman with Suspected Appendicitis is Referred for a CT Scan, What Should a Radiologist Do to Minimize Potential Radiation Risks?" Because sometimes, as I said, despite our best efforts, CT needs to be performed because there are potentially life-threatening problems that need to be addressed and can't wait until after pregnancy. So if you increase the KV, this will if you increase the KV from 110 to 140, that increases the dose to the fetus by 60%. If you increase the MAS, the dose to the fetus will increase in a directly proportional fashion. Patient size also comes into consideration here. The dose will increase as the patient size decreases. Pitch, if you double the pitch, that halves the dose. And if you use a narrower beam collimation, that will also increase the dose. So these are some of the parameters that we can think about modifying if we find ourselves having to perform a CT of the abdomen and pelvis in a pregnant patient. So what should you do? Well, you should certainly use reasonable caution and perform the test only when absolutely necessary and if you can't obtain the information by other means such as ultrasound or MRI. You can limit the volume that is scanned in order to decrease the dose. You can decrease the MAS, increase the pitch, and we believe that if you're performing a study, let's say to rule out appendicitis, you should administer oral and IV contrast, because what you don't want to do is end up with a study where you've exposed the fetus but it's ultimately non-diagnostic. So I've given you here some of the parameter changes that we would make using our Siemens Sensation 16 scanner when performing an abdominal pelvic CT scan in a pregnant patient. So we use a detector configuration of 16 by 1.5, a KV of 120. We do not use care dose. We set the effective MAS for 100. We use a table feed of 36 millimeters per rotation, which is equivalent to a pitch of 1.5. We would give 100 cc's of non-ionic intravenous contrast and our scan delay of 90 seconds. And what you can actually do, and you can work on this with your applications person, you can go to your CT scanner and you can plug in these various parameters and it will give you an estimated absorbed dose. This is not specifically a fetal dose, but it is a dose to the patient if you use all of these parameters. And actually using these parameters, this estimates a dose of 0.7 rad, so it's actually much lower than that other figure that I quoted to you earlier. And this is the kind of image quality that you can obtain using those parameters. This patient was sent in for rule out appendicitis, which she didn't have, but you can see that these clearly would be diagnostic quality images. Now, the other issue regarding CT use in pregnancy that we need to address is the safety of iodinated contrast. Now, diagnostic iodinated contrast does, in small amounts, cross the placenta, and there really haven't been any adequate teratogenic studies to look at what the effect is on the fetus exposed in utero. It's also considered that iodinated contrast may be a potential cause of fetal hypothyroidism, but it's felt that this risk is probably probably negligible at the doses of free iodine that are actually going to reach the fetus. So as with all of this that I'm discussing, what you basically have to do is estimate your risk versus benefit and use it only if you think that it's absolutely necessary. And of course, it's always important that if a fetus was exposed to iodinated contrast, that the neonatal thyroid function is evaluated after birth. I want to refer you to this article, which I also found to be very helpful. It's published in European Radiology this year, and it's entitled The Use of Iodinated and Gadolinium Contrast Media During Pregnancy and Lactation, and it deals with a lot of these issues that we think about when we're giving either iodinated contrast or gadolinium to a pregnant patient. Well, what does the manufacturer say about this? So if you look at the package insert of Ultravist, which is the non-ionic IV contrast that we use, in terms of teratogenic effects, it categorizes this as a pregnancy category B drug. And what does that mean? Well, basically that means that we really don't have any adequate and well-controlled studies in pregnant women, but at least animal studies have shown that there is no direct harm to the fetus. So that's why it's a category B. And they basically say, again, use during pregnancy only if clearly needed. Well, the ACR not too long ago came out with their recently updated 5th edition of their contrast media manual. And if you take a look at this, what are their recommendations regarding the use of CT and IV contrast in pregnancy? Well, they say that you should document in the radiology report that the information requested cannot be obtained by other means, such as ultrasound or MR. The information needed affects the care of the patient and the fetus during pregnancy. The referring clinician requests the information during pregnancy, and that you should obtain informed consent from the patient after having explained the risks, benefits, and alternatives. So it's basically a very common sense approach. Now, sometimes this comes up as a question: what should you do with the patient who is breastfeeding, who has been given IV contrast? Can she continue to breastfeed, or does she need to abstain? Well, the concern here is that of potential risk or of toxicity or allergic reaction to the neonate. Well, it actually turns out that less than 1% of the iodinated contrast is excreted in breast milk. Less than 1% of this that is ingested is absorbed by the GI tract. So there's actually an extremely low dose to the infant. So the ACR states that it is safe for the mother to continue breastfeeding after receiving iodinated contrast, but they do say that you should explain the issue to the patient, and you should allow her to make an informed decision, and she may decide to abstain for 24 hours. Leaving CT now, let's go on to MRI. This has a sort of different set of issues regarding safety. These have to do with tissue heating, also teratogenesis, acoustic damage, and then gadolinium toxicity. Now, it has been shown in some animal models that if you expose animals to to MR for long periods of time, so in this study they subjected chicks to 1.5 Tesla for 6 hours, they did find a higher rate of abnormality and death when compared with controls. But obviously we're not going to be subjecting any pregnant woman to an MR for 6 hours. But it is prudent certainly to minimize the imaging time here. And again, there have been no adverse effects documented on fetuses that have actually undergone MR imaging in utero, but there is a theoretical risk. Now, in terms of acoustic damage, there were some studies that suggested that MR may have a deleterious effect on the fetal ear. Other studies have established this risk as negligible, and this has been documented by follow-up studies of infants imaged in utero. So this is felt to really not be a significant risk. So again, where do some organizations weigh in on the use of MRI during pregnancy? Well, the FDA simply states that the safety of MR has not been established for the fetus. ACOG and the National Radiation Protection Board state that although there have been no documented adverse fetal effects reported, the NRPB advises against its use in the first trimester. And the Society of MRI Safety Committee states that MRI is indicated if other non-ionizing diagnostic imaging methods are inadequate, or if the examination provides important information that would otherwise require exposure to ionizing radiation. In terms of gadolinium use during pregnancy, Gado does cross the placenta, and in animal studies it has been associated with congenital malformations such as skeletal malformations, but there are no controlled long-term studies in pregnant patients, and we feel in our practice that it's best to just avoid the use of gadolinium during pregnancy. If you look at the package insert on Magnevist, which is the Gado agent that we use, this is categorized as a pregnancy category C drug, which means that although there are no studies in fetuses that have been exposed, there have been animal studies which have shown adverse outcomes with various congenital anomalies. So that's why it's category C. They say use only when potential benefit justifies potential risk. And finally, the ACR recommendation, they state that the safety of MR and of gadolinium-based contrast agents has not been established. Similar to CT, you should inform the patient, the pregnant patient, of the risk versus benefit and obtain consent. You should document that the information cannot be acquired by other means, that the information needed affects the care of the patient and the fetus during pregnancy, and you cannot wait until after the pregnancy to obtain this information. And the situation with breastfeeding after gadolinium is similar to that with iodinated contrast. A very small amount of this is excreted in breast milk, and a very small amount of that is actually absorbed from the GI tract, resulting in a very low dose to the infant. So the ACR feels that it's safe for the mother to continue breastfeeding after being given IV Gado, but that, again, she should be allowed to make an informed decision, and she may choose to abstain for 24 hours. So our MR protocol in pregnancy, we avoid the first trimester. Again, this is this time of critical organogenesis, and we do really try to minimize the imaging time. And you want to just sort of decide what question it is you're trying to answer and then target your examination appropriately. We do obtain informed consent. We do not give gadolinium. We use fast imaging sequences such as HASTE or single-shot fast spin echo and TrueFisp. We'll supplement that with T1-weighted images with or without fat suppression. Those are helpful if you're looking for a hemorrhage or a fat-containing mass, for instance, and we'll see some examples. So now then, with that as background, let's look at some non-obstetrical applications of CT and MR in the pregnant patient. Now, there can be many, many different causes of abdominal pain during pregnancy, and that I've listed there. The most common causes for abdominal surgery during pregnancy include appendicitis, gallstone-related complications, and adnexal masses. As far as acute appendicitis in pregnancy goes, it's reported to occur in about 1 in 1,500 pregnancies. Appendiceal rupture is more likely to occur in the 3rd trimester, and if the appendix is perforated, it is associated with a fetal loss rate of up to 36%. So this is a diagnosis that we don't want to miss. But unfortunately, it can be a challenging clinical diagnosis because many of the clinical findings, such as a leukocytosis, fever, can be seen just related to the pregnancy or can be seen with many other conditions. And the finding of pain that localizes to the right lower quadrant is still considered to be the most reliable clinical finding. Now, if you're suspecting a diagnosis of appendicitis, ultrasound should be the first study that you perform, and this is particularly true during the 1st and 2nd trimester when you want to minimize radiation dose. Ultrasound will be more accurate earlier in pregnancy, but it does unfortunately become more difficult as the pregnancy progresses. And what I'm showing you here in this diagram from the literature is the upward migration of the appendix during pregnancy. So the appendix can be mobilized upwards. It may be retrocecal in location. It may be difficult to see. Remember, you may have to actually look higher than you would expect to normally look in earlier pregnancy or in the non-pregnant patient. And if you use your high-resolution linear transducer, you are going to see, hopefully, a blind-ending non-peristalsing structure, which is non-compressible. There may be hyperemia in the wall unless it's already gangrenous. It may be associated with a periappendiceal abscess, and you may also find a fecalith or appendicolith, which we did not see in this patient. Now the problem is, and for those of us who have evaluated pregnant patients for appendicitis, well, in theory that sounds great, but in practice it truly is very difficult many times. So you're often left with an unanswered question, and the question is, what should you do next? Well, there's a trend now, and there have been several reports in the literature, that in the pregnant patient you may want to consider MRI as the next best diagnostic imaging method. And I'm showing you an example here. This is just a coronal haste image. This fetus was about 17 or 18 weeks. The mother had right lower quadrant pain. The ultrasound could not identify a normal appendix, and so she was assessed with MRI. And if you look carefully here, you'll see the appendix right here. It's retrocecal in location. Even without gadolinium or oral contrast, you can see that this appendix looks normal and that it's non-dilated and there are no periappendiceal fluid or inflammatory changes. Here, on the other hand, is a woman who's at 29 weeks. Again, ultrasound was non-diagnostic. We brought her to MR. And again, we just did coronal haste images here. And here we see the appendix, which is now distended and fluid-filled, and it has this appendicolith, which is this low signal intensity focus right here. And if we look at the cine clip, again, I just wanted you to get a feel for this. We're going to be looking over here. Here's the appendix right in here, and it's kind of compressed between the gravid uterus and the cecum here, and you can see there's a normal right ovary here, which helped us to exclude as adnexal pathology as the cause of the patient's pain. Now, if you're not, if you don't have access to MRI, or perhaps you don't feel comfortable interpreting MRI for appendicitis, particularly without Gado, you may want to consider doing a CT, because again, you have to judge the potential risk of missing a perforated appendicitis versus the theoretical risk of the radiation dose to the fetus. And there really is limited data out there in the literature describing the use of CT in the pregnant patient for looking at appendicitis. This was a small series out of the MGH, where in 7 pregnant patients, they had 2 with path-proven appendicitis, and both of those were diagnosed at CT. Here are some examples from our practice. So here's a woman at 25 weeks gestational age. We see a normal appendix here. Again, it's located between the gravid uterus and the cecum. I think if you didn't give oral contrast, it would be very difficult to see this. What you might want to do is turn the patient a little bit in the left lateral decubitus position, and that may make visualization of the appendix a little bit easier. Here's another normal air-containing, non-dilated appendix in a 20-week gestation. Here, on the other hand, is acute appendicitis in a 28-week gestation, and we use the same criteria that we do in the non-pregnant patient. We see a distended, fluid-filled appendix with thickened enhancing wall and periappendiceal inflammatory changes. And here is another acute appendicitis at about 16 weeks, and here we see that there is lack of filling of the appendix with oral contrast and periappendiceal inflammation. Acute cholecystitis is the second most common non-obstetrical surgical condition in pregnancy. It usually is associated with gallstones. There is a higher rate of gallstone formation in the pregnant patient. And of course, ultrasound is going to be the study of choice and usually will be diagnostic. You may want to consider doing MRI and MRCP if you're assessing for common bile duct stones. We very rarely would perform a hepatobiliary scan. Percreta does cross the placenta, and it results in a fetal dose of about 0.15 rad. And here's an example of a woman who had a twin pregnancy here, and we see that there is, on this thick slab image, a filling defect in the common bile duct consistent with a stone, and we can also appreciate that on the coronal and axial haste images. Acute pancreatitis in pregnancy usually occurs in the setting of gallstone disease, and this can result in preterm delivery and fetal death if it is severe. You can use ultrasound to look for stones, MR if available to look for peripancreatic fluid collections. If you're concerned about necrosis, then again you may want to consider contrast-enhanced CT. And here's a patient with pancreatitis. We can see peripancreatic inflammatory change and fluid, but there is no evidence for necrosis. Looking at the kidneys, well, physiologic hydronephrosis of pregnancy is common. It occurs in 90% of asymptomatic women during pregnancy. It can begin as early as 11 to 15 weeks. It's probably related to progesterone causing smooth muscle relaxation and ureteral dilatation, as well as mechanical compression of the ureters. It is more common on the right side. Urolithiasis complicates about 1 in 1,500 pregnancies, mostly in the 3rd trimester. Fortunately, most of these stones will pass with hydration and pain control. But ultrasound, once again, is going to serve as the initial imaging modality for the assessment of flank pain in the pregnant patient. Now, you do have to remember that if you see hydronephrosis, you have to ask yourself, could this be physiologic? You can do Doppler evaluation of the kidneys, and it's been reported that resistive indices will be increased if there's a obstructed collecting system. However, there is conflicting data regarding this in the literature. You can look for the presence of a ureteral jet, which helps to exclude a complete obstruction. Again, if you're not seeing a jet on one side, you might want to place the patient in a decubitus position on the other side to get some of that pressure off the ureter. And then, of course, you're going to look for a stone. So here's a patient with right-sided hydro. The left kidney was normal. She did not have a right-sided jet. And if you look carefully, here is the culprit, this obstructing stone in the proximal ureter. Here's another patient with right-sided hydronephrosis, and here we could see a stone at the UVJ. If you can't see it transabdominally, and sometimes it's difficult in the pregnant patient, because of just the uterus is sort of compressing the bladder, consider doing transvaginal scan, and that sometimes will very nicely show you the UVJ stone. You can perform CT. This is an example I got from the literature showing this obstructing UVJ stone. I took it from the literature because I didn't have an example. If I were going to do this, I would not give IV contrast, and I'd probably drop the MAS even lower because you're looking for a renal calculus, so it's kind of a high contrast abnormality. Here's physiologic hydronephrosis of pregnancy at MR, and MR is an option now to look for an obstructing ureteral stone. And what you're going to see with physiologic hydro is just a tapered extrinsic obstruction of the ureter at its middle third. And here we see it in the sagittal plane right here. If you're going to do MR to look for stone, again, perform a T2-weighted haste or single-shot fast spin echo sequence. Stones will appear as hypointense filling defects. The problem is you may not be able to see small stones, and you may mistake flow artifact for an obstructing stone. And here's an example in a non-pregnant patient with hydronephrosis and hydroureter, and here you see the obstructing stone. Adnexal mass characterization, ultrasound is going to be the study of choice. If inconclusive, MR can serve as a problem-solving tool. Here's a 25-year-old woman with the 1st trimester of pregnancy who has a large mass. It wasn't clear if this was related to the uterus or adnexa. She came back in the 2nd trimester. Here we see the mass. We saw 2 normal ovaries, and this was just a large degenerated subserosal fibroid. Another patient with the mass in the cul-de-sac seen on ultrasound. We can see that it is iso-intense to pelvic fat. It drops out on the fat-suppressed image, confirming the presence of a dermoid. In the last 5 minutes that I have, I just want to quickly show you some obstetrical indications of MRI. This has become possible now because of the development of fast MR imaging techniques that minimize artifact related to fetal motion. Sometimes it's difficult at ultrasound, particularly if the patient presents in the 3rd trimester for her first scan, to clear the cervical os of placenta and rule out a placenta previa. Here we see a posterior placenta on an MR on the sagittal haste image. You can see the internal os very nicely. Clearly there's no placenta previa here. On the other hand, in this patient, there is a marginal placenta previa because the inferior leading edge of the placenta covers the internal cervical os. Placenta previa may be associated with placenta or placental implantation abnormalities such as placenta percreta. Sometimes you can diagnose this on ultrasound. Here we see a previa and we see placental vessels extending to the wall of the urinary bladder. But MR can also be very helpful in this regard. And here we see the placenta, and clearly there's a very irregular contour to the bladder dome, and this was confirmed as a placenta percreta at surgery. And this was a series published by Dr. Levine and colleagues from Boston, and they found MR could be helpful in those patients with the placenta difficult to assess by ultrasound. And then lastly, to look at complex fetal disorders with MR. This is not used as a screening test. The exam is tailored to address a specific question, and it can be used as a problem-solving tool. It may also supply additional information if there are unanswered questions at sonography that may impact on how the pregnancy is managed and how the patient is counseled. It's been shown in several studies that MR is very helpful, particularly for looking at fetal CNS abnormalities. Here's a normal fetal brain in the late second trimester. On the other hand, here's a fetus with agenesis of the corpus callosum. We see no corpus callosum, and we see the dilated occipital horns of the lateral ventricles, consistent with colpocephaly. Here's a fetus who had a mass in the region of the nose and face on sonography, and it wasn't clear. Is this a teratoma? Is it an encephalocele? So she was sent to MR for further assessment. You can clearly see that there is extension of brain tissue into this mass. There's a large porencephalic cyst. This was a frontal ethmoidal encephalocele. And this is an example of a meningocele that we see here. And this patient was difficult to image at sonography because the fetal spine was right up against the uterine wall. And my last case here, this was a case we saw not too long ago at Bellevue. It was a 25-year-old woman who presented for her initial prenatal visit at 39 weeks gestational age. She was basically sent over to ultrasound to confirm size and dates and get an estimated fetal weight. As soon as we started to scan her, we saw it was very abnormal. We saw that the fetal heart was shifted way over to the right side of the thorax, and then in the left thorax there was this large complex mass which looked like bowel. We saw that there was basically no bowel below the diaphragm, and we felt that this was consistent with a congenital diaphragmatic hernia. The surgeon who was going to operate on the fetus wanted to characterize this a little bit further before the fetus was delivered, and this is a true FISP. This is a haste image, and it shows you that basically all of the fetal bowel was located in the thorax, and here's the heart, which is shifted way over to the right. And this fetus actually did well. After being delivered, the surgeons performed surgery thoracoscopically to repair the diaphragmatic defect, and the baby did fine. So in conclusion, I again would stress that ultrasound is the test of choice during pregnancy, but consider MRI as an important problem-solving tool if ultrasound is inadequate. And then think about CT, avoid it when possible, but you have to consider the potential benefits possibly outweighing the risk. And then think about some of these technical modifications in order to minimize radiation dose.